So good evening, everybody. Welcome to this program of interventional cardiology. We have decided that besides coronary intervention, we will be discussing on different kinds of intervention, which could be peripheral interventions, it could be electrophysiological studies, it could be related to devices like the CRTDs. So today we have selected that Dr. Devinder Singh would be talking on CRTDs, the tips and tricks. Dr. Tripathi would be talking on a very, very interesting topic, acute closure of coronary arteries during the PCI. And Dr. Nag would be talking also on a very, very contemporary and burning issue of OCT imaging in coronary calcification. And Dr. Rai obviously would be talking on the ultimate of interventional cardiology, that is unprotected left main PCI. And we believe that he does not have actually a cardiovascular surgical backup in his center. So all the more risks Dr. Rai takes for doing his cases. So without much ado, let me start with a small presentation, and then we can go back to Dr. Singh for his first presentation. So today, I'm pretty happy to say that we have 15 lakhs happy hearts who have implanted Zion's stent uh, in the coronary arteries. So that's a huge achievement from where we started. And so this Zion stent is the everolimus drug-eluting stent system, and we will be just touching on the sustained safety and efficacy of the system, because as we know, the uh, coronary artery stenting is a scaffolding which we started off in 1987 by Dr. Sigwart, and then it has evolved over the years and years and years, and it has come to from bare metal stents to drug-eluting stents, and then we had the stents without the scaffold, that is the bioabsorbable stents, and then everything stopped for a while. Now we discuss about how to deliver the stents safely. We talk about the safety of the stents. We talk about the efficacies of the stents as well. So the question is, with the progress of DES, are we finished or not? So we have an interesting paper by Dr. Capadano in 2019, where he discusses about are there any areas of improvement for contemporary drug-eluting stents. So what are the issues really? Failure is not zero because we still have a 5% target lesion failure at 1 year. So that's something which needs to be addressed. We have also the high risk patients coming up more and more, particularly the diabetic population, particularly in the Southeast Asia and the Indian subcontinent, where diabetes is like a pandemic. And so these are the category of patients where currently the data shows that a CABG scores higher over a PCI. So definitely the drug-eluting stents and the stent industry has some way to go to match the cohort of patients who are going for CABG, particularly the triple vessel disease and the diabetic patients. So there is some need for progress there as well. Then we have issues of in-stent restenosis because of neoatherosclerosis. Then we have the fractures of the stents because we are using high pressure balloons nowadays, and we are also using thin strut stents. So both these factors can actually cause these fractures of the stent. So these are the issues which needs to be addressed, because we need thin strut stents for so that the subacute thrombosis rates are less, deliverability is good. At the same time, we want that the fractures don't happen, so the radial strength of the stent needs to be high. So then we talk about a very, very important issue with the dual antiplatelet therapy. Exactly what is the duration of the therapy, which will be safe yet efficacious for the patient. And fifthly, we talk about the technical issues like the deliverability of the stents, the balloon on the stents, uh, the coating of the stents, the drug deliverability. These are the issues, and also the scaffolding of the stents, how quickly it is absorbed if we are using bioabsorbable stents. Because I believe that bioabsorbable stents are not finished yet. I think next generation of stents are going to come. So these are the areas which we need to kind of find out in the coming years about the drug-eluting stents. Then we have the Zyme stent, uh, the evidence-based choice, because we have 15 million implants already in this world on the Zyme stents. We have a lot of data, 120 plus clinical trials, about 125,000 patients studied already, and more than 10 years or a decade of data available to us. So we have got excellent and consistent acute patient outcomes with the Zyme stents, particularly for primary PCIs. We have large body of data on complex PCI and complex patients, and also on the long-term patient outcomes. We have got a lot of evidence, and we have this DAPT2 trial, which has got proven with short DAPT regimes for this Zyme, particularly the Zyme stent. And there is a continuous design improvement, so that we have thin strut stents, we have deliverable stents, which doesn't break, which doesn't cause subacute thrombosis. So these are the issues which needs to be discussed in the coming years. So every device, as we know, has two issues. One is to deliver the device to the particular area where we want it to go, and to be safe and still efficacious. So basically, the efficacious and safety are the two issues which needs to be balanced properly, and that I think the Zyme stent has been doing so far. It's with its multi-link stent design. It's a good and optimized delivery system. It's got a fluoropolymer coating, and it's got everolimus drug, which makes a good combination for the stent. Uh, Now, the process of albumin binding leading to thromboresistance through fluoropassivation and facilitating safe endothelialization is an important issue, because if we know that if you bind albumin or any protein to a drug, the delivery of the drug can be done in a very focused way, and also the rate of delivery can also be influenced with this binding of the proteins. So if you have a thromboresistance, then obviously you have definitely a lesser chances of stent thrombosis. And also, with the very important one is, we don't want the area of the endothelium to be kind of exposed to the stent for a long time. So the endothelialization of the stent is a very, very important issue, because the earlier the endothelialization happens, the better it is for the arteries, and the lesser the chances of thrombosis. And now, this particular trial is a very important landmark trial in the stop DAPT science trial, because the $1 million question has been, how long should we actually be giving the dual antiplatelet agent? So this particular trial has shown that among the patients undergoing PCI for stable and unstable cardiovascular disease, 1 month dual antiplatelet therapy followed by clopidogrel monotherapy was superior to 12 months of DAPT followed by aspirin monotherapy at preventing net adverse clinical events. And this is a very, very important thing, because 1 month of DAPT was non-inferior to 12 months of DAPT at preventing major adverse ischemic events, and superior to 12 months of DAPT at preventing TIMI, major and minor bleeding. So this design of this trial is like the global leaders trial. So I think this particular trial was done with this Zyme stent. So we have good data to show that 1 month DAPT followed by clopidogrel monotherapy is actually way to go, and that will reduce the bleeding complications as well. So what I'll do is, now I finish my presentation, and I would like to invite Dr. Devinder Singh to start his deliberation. But before doing that, let me give a brief introduction about Dr. Devinder Singh. He's a very close friend of mine and a colleague of mine from the days of Singapore, and he has been doing very, very good work. I hear, and I've heard very good things about him in the recent times. He's a senior consultant in the Department of Cardiology at National University Hospital and assistant professor, Department of Medicine at the National University of Singapore. He has done his main training at the Duke University Medical Center in advanced clinical cardiac electrophysiology. And he's also done fellowship in cardiac magnetic resonance imaging at Duke University Medical Center, and also has advanced specialty training in cardiology in Singapore. And he's actively involved in academic works. He has also contributed to various textbooks as well as to international and national medical journals on topics relating to cardiovascular conditions and procedures. So with this brief introduction, I hand over the platform to Dr. Devinder Singh for his topic of CRTD, the tips and tricks. Over to you, Dr. Devinder Singh.
Thanks, Dr. Dev, for the kind introduction, and thanks, Abbott and Dr. Dev, for inviting me to talk and share with you guys. Just give me a moment. I'm trying to share. Yeah. Can you guys see the slides?
Not yet.
Just a moment. Okay. Now?
Yeah, we can see it.
Yes.
Great. So today I'll be talking about tips and tricks of implanting a CRT, and I will just show you direct cases, and on the way we will during this presentation we can it's like a open discussion. You can stop me anytime if you have questions. This is our hospital. Dr. Dev has worked there before, and I will start with the case. This is a lady this is a guy who had a complete heart block and a pacemaker done. His ejection fraction was 55%, and he was completely pacing dependent. And after 2 years of ventricular pacing, his ejection fraction dropped to 30%. And there was a plan, so we decided it's a pacing-induced cardiomyopathy and decided to upgrade his device to a CRT-P. This is ECG. You can see that he has been RV paced, and this lead is actually placed in the RV outflow tract. That's why the inferior leads are positive. So we start when upgrade is always challenging because you have a lead present in the system for maybe many years, and we use for every case, even for a new device, we always start with a venogram. We inject 10 cc contrast through a peripheral plug, and as you can see that the contrast is coming in. There's not much of obstruction you see right now here in the venous system, so we got access. You guys can see the slides, yeah?
Yes, we can, Dr. Devinder.
Okay, so but as we are trying to put in our J wire in, you can see at the junction of the left brachiocephalic with the superior vena cava, there may be a stenosis here, and we are not able to cross the wire. So we went ahead and put in a sheath in and took a shot. You can see there are a lot of collaterals, and there's a stenosis right here at the junction of the left brachiocephalic with the superior vena cava, which is a quite common site for stenosis. And that's the reason we can't cross our wire here, and you can see collaterals maintaining the venous flow. So what should we do next, actually? Because the options are, if we really want to go through here, we have to cross this stenosis. Otherwise, we have to shift the whole device to the right if we really want to upgrade him. This is a contrast injection through the dilator. So we tried to cross this with a thermo wire, which is a hydrophilic wire 035. And after some manipulation, we were able to cross it. And just to make sure that we are in the true lumen, we went ahead and went into the right ventricular outflow tract and the pulmonary artery. So just to make sure that we are in the true lumen of the vein. Next, we now are trying to cross this. And you can see that dilator is not going over the wire, and the stenosis is really tight. We can't cross our dilator. So what should we do next then? So we decided to do a balloon angioplasty, used a 6 by 40 millimeter balloon, peripheral interventional balloon. And you can see there's a waist when we inflated the balloon here. And we did some further ballooning down in the SVC as well. Once the stenosis, once you have ballooned it, we can easily pass the outer guide. And we usually access coronary sinus with the AL2 and a Terumo wire. This is the coronary sinus. We are going into the coronary sinus, and you can see the outer guide is up here, which is Medtronic's MB2. And you can see the patient's previous RV lead is in the outflow, RV outflow tract and the atrial lead. And we managed to put in a coronary sinus lead without much issues after that. And as you can see, this is the lateral view. It's quite lateral, and there's nice separation between the outflow and the coronary sinus lead. This is an AP view of the same device. And post procedure, there is some narrowing of the QRS complex. And this patient's EF improved to normal after 3 months. So any questions? I can move on, or otherwise I'll move to the second case.
Yeah, I was just wondering, the ejection fraction, Dr. Singh, was about 55% and it came down to 35%. So what was the reason for it? Did you do check angio to find out?
The coronary angiogram was normal, and we believed it's pacing-induced cardiomyopathy, long-standing RV pacing leading to dysynchrony and causing cardiomyopathy.
Dr. Nag, do you have any questions on this case? Dr. Nag, you are muted, I think.
Yeah. Devinder sir, is there so much of drastic improvement in the ejection fraction after post CRT?
Yes.
Or is this more of the symptomatic improvement, sir?
No, not only symptomatically, but the ejection fraction also improved. So if pacing-induced cardiomyopathy is is something which is not well recognized, right. But if you see it and you act on it, actually it does help.
Right.
And
so what was his class of NYHA when he started off, and what did he end up with?
The reason the echo was done was she started developing failure symptoms, and that's right, because we don't routinely do echo even in patients who are pacing dependent, but it's basically a symptom based echo. So patient was having shortness of breath, NYHA class 2, 3, and we went ahead, did the echo, noted that EF has gone down, did angiogram which was normal, and that's why we planned to.
Did you do any tissue Doppler to find out what was his?
So the tissue Doppler's velocities were low, systolic velocities were low, and you can actually, if you can see even visual synchrony. Although we don't do synchrony nowadays as routinely for patient who requires pacemaker or CRT, but he had visual dysynchrony even on.
So for the sake of our viewers, I mean, the criteria for pacing for doing the CRTD, is it just based on ejection fraction, or do you have additional criteria which you go by?
Any patient who has who requires pacing more than 40% of the time, and if there's a drop in ejection fraction to less than 45 on pacing, and we believe it is pacing-induced cardiomyopathy, there is an indication of upgrading his device to a CRT.
So, but you can still have pacing-induced arrhythmias also, isn't it? I mean,
yes,
if you do a CRTDs, you can still. That is one of the very low complication, but it's still possible.
Possible, yes. It's a possible complication. And if you may have noticed that this device is not a CRTD, it's a CRT-P. There is no defibrillation lead, and this is she's like in her late 70s. So to begin with, the device was done for complete heart block. That's why it was just a pacemaker. And when we upgrade,
okay, I think you can go on to your next case, Dr. Devinder. Yeah.
Okay. So the next case I'm sharing is about difficult CS cannulation, which is not a uncommon problem. You know, getting CS access is one of the most important steps when you are implanting a CRT. And I'll just talk to how a groin approach can help sometimes. So you can see that in this patient, the CS os is actually very posterior, and in spite of repeated attempts with different methods, we were not able to get into this CS. So, and you can see RV lead is already there, and the third wire is for the RA lead. So we went ahead, and we don't do that commonly, but we went ahead from the groin. This is SL3 sheath. If you guys are doing EP, you will know that sometimes when for EP procedures, if we have
I
difficulty,
think you need to share your screen, Dr. Devinder.
is it now? Is you guys can see it?
No, we can't see the screen.
Yes, yes, it is visible, sir.
I can see. It's visible.
Yeah, you can see it. Okay, okay, good,
Yes.
good.
Right, right.
Yeah,
Just a moment, then I'll go to setup. Okay, can see it now?
yeah,
Yes.
yeah.
So if you guys are doing EP work, you know that SL3 is a sheet which can help us go into, because it has a S-shaped curve at its tip, it can help you go into the coronary sinus. And so we went from the femoral vein. You can see that we have a shot of coronary sinus now. And the MB2 sheath has a deflectable decapolar coronary sinus catheter, so that it actually can help you go into the CS as well. And with these tools, we were managed to get into the coronary sinus. And the dilator, and this is actually a coronary catheter. We are just trying to get some support to go into the CS. And we routinely do a balloon occlusion venogram. So this is a balloon occlusion venogram just to show you the branches of the coronary sinus. You can see a very faint flow down here, which is like a posterolateral vein. Just a second. So once you have your access, it's easier to go ahead with. So this technique, sometimes if you have problem getting coronary sinus from the top, actually you can get access from femoral vein as well. Any questions?
Yeah, Dr. Rai, any questions?
Okay, sir. Yes, continue, sir.
All right, so I'll move on. Sometimes when you are doing coronary sinus shot, balloon occlusion venogram, you may not be able to get a good venogram. You can see that CS is really large, and the balloon is just actually floating in spite of full inflation. Balloon is just floating in the coronary vein. Coronary. So how do you get? You can't see your branches well if you can't occlude it well. This is the RAO shot, and the earlier shot was the LAO. So what are the things you can do now actually to see the branches? So one of the technique which you can use is you go into the distal part of the coronary sinus where the caliber is much smaller. You can see where we can easily occlude it, and you can see that there is a branch which is coming in. It's a large posterolateral branch. The RAO view will be more clear. You can see there is a posterolateral branch coming in here, which was earlier not seen. So it is very important to occlude your coronary sinus well to get a nice view of all the possible branches, because that's how you can plan where you can put your lead in actually. But you can see that if we go into the later part of the shot, the branch will come in here. The os is actually, it's a slightly angulated os. So that's why we were trying to, apart from the outer sheaths, you can use an inner guide which is an angulated guide. This is a 135-degree angle, obtuse inner. So we are trying to find the ostium of that branch, and we are having difficulty getting into the ostium. So, but we know that there is a branch there. So what are the things you can do if you can't get into the ostium, or you can't find the ostium of a nice branch? So we have now access into the, with a J wire, we are maintaining our access in the coronary sinus, and there's another uh, lead wire, which is a thermo wire, which is going into the middle cardiac vein. Which middle cardiac vein is not an ideal vein to put in lead. So we are still trying to figure out our posterolateral vein. The os is somewhere here. So, but once we get into the middle cardiac vein, we actually have introduced our outer guide and deep throated it into the middle cardiac. And we are taking a shot of the middle cardiac. And you can see once you are in the middle cardiac, you can see the posterolateral branch more clearly. You can see there is some local dissection and some staining here, which is
Yeah.
because the size of the catheter is, the outer sheath is bigger. But at least we know that this branch is right here. And then there are some collaterals which goes from the middle cardiac to the posterolateral branch. So we can potentially go from middle cardiac to this branch as well. So this is what we are trying to do here. This is another shot. So we managed to go through these collaterals into the posterolateral branch. You can see the wire, the 014 wire is coming back into the coronary sinus, the main body here, through the posterolateral branch. This is another view of that alley shot. So what we were trying to actually, because this collateral is very small, so we are trying to do some venoplasty actually. We are making these collateral bigger so that we can put in our lead through this collateral into this branch. So these are non-compliant balloon. Actually, you can do venoplasty for the smaller branches as well. But in spite of that, we could not cross the lead through these collaterals. So then we went ahead and we actually used AL2. AL2 has a bend. We managed to get into the branch os, and we have more idea, where that os is from the previous shots. So we managed to get into the managed to get the AL2 into that branch, and then over thermo wire in the bigger branch, and then over that we managed to put in our guide in, and you can see that it's much easier to deliver your lead once you have your outer supporting cath is inside the branch itself. This is another RO view of that same, and this is the final shot. So we have yes, lead into that posterolateral branch, which is one of the good branches for pacing. Any questions about this?
Yeah, I think you need to find out whether you plan this by doing angiogram beforehand, or do you do it straight on
No,
the table when you are
on the
actually
table
taking
itself.
the patient up for the
On the
device?
table itself. So although if we really want to know the branches, we can do a CT of the coronary sinus, especially if we are anticipating difficulty, or even an MRI with contrast, we can get coronary sinus branches. But we don't routinely do it, and we don't really anticipate problems because getting coronary sinus access is quite easy. But there are patients where we have trouble getting access to, and sometimes there are patients where we have trouble finding branches.
What are your percentage of cases where you actually could not do it and then go for epicardial left ventricular lead?
It's almost zero. We hardly have problem
Yeah.
with
Somehow you managed to actually put it. But
yes.
is it possible that you have put it and then the wire has been deflected out?
Yes, it is
Have
possible.
scenarios like that?
And right now there is option of his bundle pacing as well. So if we don't get into the CS, or the CS branches are the thresholds are not good, or if you have recurrent phrenic nerve capture, so even though you have access, you have leads in there, but there's problem with capture, uh, or problem with phrenic nerve pacing. actually we can offer these patients same time we are already there. We can do a his bundle pacing, which is as good as doing a CRT-P because your
Good.
QRS is pretty narrow and it's also physiological.
And the final question to you, Dr. Singh, for this forum would be that in what cases would you do a CRT-P versus a CRT-D? I mean the ICD.
So almost all patients who have poor EF and NYHA class 2 or 3 with the EF of less than 35%, when we offer them CRT, invariably they get a defibrillator because there's an indication for primary prevention defibrillator.
But what about patients who have got an ejection fraction about 40% and who requires a
So
CRT-D? CRT.
uh, in those patients, we usually have a discussion, and I may not personally do defibrillator with them because it's not indicated.
There's no evidence, strong
Yeah.
evidence for that. Yeah.
And then another group of patients which I may not do a defibrillator is patients who are in their 80s. So we don't have enough data for elderlies for primary prevention ICD. So usually I discuss with the patient and offer them either a defibrillator or CRT-P. So it's actually depend on patient preference as well.
Okay, Dr. Rai, if you have any
Sir.
more questions.
Yes, sir.
Yeah.
How is the practice of while taking this coronary venogram? How is the practice of taking this venogram in lieu of his venous phase in routine angiogram?
Oh, you
Suppose,
can do that.
yeah,
So you can take a long coronary shot.
short, yeah,
That can help you see branches as well. But
right, right,
you have to get a arterial access, and
right.
it adds an extra step. Or sometimes most of these patients have previous coronary angiogram done, and before you start your procedure, you can
Yeah.
actually go through their
Suppose
angio.
we know mother whom we are planning for CRT, also we are considering for CRT. We do angiography. Obviously, we have to rule out the ischemic heart disease for this one.
So at that
So
time,
we
you do
do
LIGO phase and
most of
look
the
at
cases we do angiography. So in that case only, mother, we can take a long venous shot like that. Is it?
No, it's an option, but the problem is
Yeah.
you still may not be able to see all the branches.
Right, all the branches.
But once you occlude your coronary sinus,
Right.
most of your branches will be clearly seen. And
visible.
while doing your procedure, you need it because you can guide your wires then.
Right, right. And sir, one that post pacing जो LV dysfunction candidate for CRT. So post pacing patient going going
Upgrade
into
of
LV dysfunction.
your.
Apart from after ruling out the ischemic, apart from post pacing जो dysynchrony and dysfunction, what other reason can be?
Okay, so if this other reasons could be patient has maybe some kind of developing a idiopathic dilated cardiomyopathy. Patient could have an infiltrative disease,
Right,
which
right.
could be amyloid, which could be hypertrophic cardiomyopathy. So if
Right,
there are obvious other reasons which can explain patient's cardiomyopathy, we can diagnose that as well.
right.
We actually
Thank you.
usually don't do MRI for these patients because they already have a device. So
Right.
to diagnose infiltrative cardiomyopathy, it's not easy, or you have to
Right,
do
right.
RV biopsy actually.
Yeah, right, right. Thank you, sir.
So what is the approach of offering LBP pacing in those patients who are a candidate for CRT-P? We can offer them LBP pacing. What is that? What you will take on that approach?
So you are saying about his bundle pacing or CRT?
His bundle pacing in those candidates who are a candidate for CRT-P.
Yeah, yeah. So we do, especially patient who have, that patient who have right bundle branch block. The data is limited about CRTD benefits. In these patients, there is a circulation paper from American group which shows that RBB with LV systolic dysfunction, his bundle pacing is actually maybe better than doing a CRT-P or D. So patient who have right bundle branch block, broad QRS, we are now routinely doing his bundle pacing.
And what about the patient with LBP and
LBP also there is data, but the problem is to get left bundle while doing his bundle is actually not easy. So
we will ask our final questions from Dr. Raja Nag. If you could unmute yourself, Dr. Nag, and ask a final question to Dr. Singh, and then we can move on to your presentation. Dr. Nag?
Yeah, that was an excellent case. And we have seen this before also, where there are stenosis in the venous route, and then venoplasty is done, and usually we are successful in implanting a LV lead. Now, thing is, like, the question by Dr. D.P. Rai is whether we should go for an occlusive venogram, which is very much essential, like Dr. Devinder Singh has explained. I also do all cases occlusive venogram before going ahead with the implantation, because other than that, we don't know like what branches are coming off, because non-occlusive venogram doesn't give us a full picture.
Yes.
Thank you.
Right.
Thank you, Dr. Singh, for your excellent presentation. We will definitely have more of you in the coming forums, and we have lots of questions, obviously, on this kind of topic. So please be with us for future forums as well.
Yeah.
And thank you again from joining from Singapore. We will move on to our next presenter, Dr. Raja Nag. Dr. Raja Nag is a consultant interventional cardiologist, obviously a very senior person in the field of intervention at a young age at Apollo Gleneagles Hospital for the last decade. I know him, and he also has experience in working in different parts of India, like Vijayawada and Baroda, and also at Parampur. Dr. Nag has a vast experience in interventional cardiology, and his area of interest are complex transradial angioplasty, valvular interventions, CTOs, bifurcations, and as he was talking about the CRT-P and CRT-Ds, and also has a lot of experience on imaging, coronary imaging like OCTs and IVUS. So he has lifetime association with various national and international eminent cardiology society, and also an eminent speaker, which I witnessed in various national and international forums. And Dr. Nag also has various national and international paper publications, and also part of numerous clinical trials as a principal investigator. So, Dr. Nag, I give you the forum for talking about the imaging with OCT with coronary calcification. Over to you, Dr. Nag.
Thank you, sir. Thank you for your kind words. I'm honored to be here, and I'm going to share my screen now and start my presentation. Can you see?
Yes, we can see, Dr. Nag.
Yeah. So basically, I have a very simple case to present with. It is not a nightmare. It is not very eventful, but I will just demonstrate how imaging helped me in this complex PCI. So this was done recently in the times of pandemic. So this gentleman presented in the ER on 29th of July, 70 years man, hypertensive diabetic, presented with NSTEMI with troponin elevation, good LV function, and normal renal function. So as a protocol in Apollo, we do HRCT test for everyone until the RT-PCR report comes. HRCT test was negative as certified by my pulmonologist. Then we went ahead and did a RT-PCR. RT-PCR was negative. So next day morning, I took him to the Cath lab, did an angiogram. So this is the right coronary, which is more or less normal. This is the left system. You can see a proximal LAD calcified lesion. And the LCX shows some ectasia in the proximal part. So we decided to go ahead, since this is a calcified lesion and we don't know what we are dealing with, we decided to go with imaging, that was for sure. And then we went radial with 6 French JL guide and see on blue wire. And we decided to first see the OCT images and then take our decision from there. So OCT image pre-dilatation, this is before even pre-dilatation. So we did this run and we showed eccentric calcium in the middle part of the lesion, which extended more than 8 millimeters. So this is where the eccentric calcium you can see from 6 o'clock to 9 o'clock position. Then we decided we'll go ahead with the new technology of shockwave lithotripsy with a 310 mm balloon, and I delivered 60 pulses. Inflated after delivering 60 pulses, we inflated it at around 6 atmospheres again. So there was no waste, and did a angiogram. This is the OCT run again. This is a post-IVL OCT. So in the moving images, we cannot make out the cracks. I'll show you one static image which very beautifully depicts the cracks made in the intimal calcium. This is the crack you can see in the 6 o'clock position as well as in the 9 o'clock position. So we went ahead and stented with the drug-eluting. Oh, there was a problem with my thing, I think. Let me go back again.
Yeah, please.
It crashed. So, yeah. So this was where we ended. Now we did shockwave lithotripsy. I've shown you this. This is the drug-eluting stent report, and this is the final shot. This is the post-stenting OCT images which we did before post-dilation. And this was very well opposed, and I'll tell you why. Because we took the reference diameter, the minimal lumen area, everything into consideration before selecting the stent size and the length. And this is how we ended up. And I did not do a post dilation in this patient because the stent was well opposed without any edge dissection, and there was no mal expansion or non-expansion areas. So the messages from this case for me is calcium in coronary lesions is common. Imaging helps to plan and execute. Precision and optimum results is mandatory to achieve better outcomes, like we saw in the beginning of the introductory slides. And shockwave lithotripsy is safe and effective even in untrained hands. Thank you.
Thank you, Dr. Nag, for this excellent contemporary case. I have a couple of questions. When you when you saw this angiogram, obviously we see a lesion in the left anterior descending artery. How do you decide which case you want to image for calcium? I mean, what are your kind of gold standards for doing that?
Yes, sir. There are now scoring methods by which we decide whether we can deal this kind of calcium with either a NC balloon or a cutting balloon or a rotablation or a shockwave lithotripsy.
No, I actually wanted to know, how do you decide that you want to image this lesion? Because would you image every lesion?
First of all, I would be like, it would be very arrogant to say that I would like to do imaging in all studies, honestly.
Fantastic. Fantastic.
I
Absolutely.
would
That's what I
love
wanted
to
to
do
hear from you.
imaging in all coronary angiogram cases given to me, given if the choice is there. But we know the cost constraints we have with our patients. So when the hands are tied, of course, we go ahead with whatever armamentarium we have, tools we have in hand. That is the reason, sir. For me, every case needs imaging because we always end up in some cases where the stent is not expanded to the stretch we want to, even after OCT also. So these are the cases which have a higher MACE in the long term. Our whole idea is to not to give a TIMI3 flow immediately on the table. We need to reduce MACE in the long term. The 5-year outcome should be better.
My next question would be that what modality of imaging would you want to do and why? I mean, would you do a CT coronary angiogram, or would you do a IVUS or OCT? How do you decide which you want to do?
Yeah. Firstly, it depends on where the lesion is. If the location is not left main or a proximal lesion in the left main, then I would always go for a OCT, provided the patient has a normal renal function. Although in impaired renal function also, we can do it with dextra and there are results, but I prefer to do it with contrast. I have a better view of the lumen.
Yeah, Dr. Nag obviously wants the OCT to be done because OCT is the only tool where you can actually see the depth of the calcium. If you do a IVUS, you can see the circumferential of the calcium. You can see the length of the calcium, but for the depth of the calcium, which is so very important to decide what modality you are going to do to crack the calcium, you need the depth. And for OCT is one of the best tools to do that. Sometimes we do CT coronary angiograms to find the calcium load, but those were actually days when we did not have these kind of imaging. So whether it's IVUS, whether it's OCT, if you ask me if you have an option and there are no contraindications, I totally agree with Dr. Nag that OCT would be the way to go. Now the next question is, how do you decide what is the modality of cracking the calcium? Like, do you do an NC or a rotablator or now the IVL?
So basically, we look at the quadrant of the calcium. Basically, if it is more than one quadrant, that means it is more than one right angle. It will not be cracked open by a NC balloon or a normal plain balloon. So those cases will definitely need a cutting balloon at least. So if the quadrant of calcium is more than 270 degrees, there is a scoring system which adds up 111 according to the quadrant, the length of the calcium, if it is more than 5 millimeter, and the depth of the calcium. In this scoring system, if it is more than 2, definitely we need a better tool to crack the calcium, like a rotablation or a shockwave lithotripsy.
Yeah, I think this scoring system was developed by Fujino et al. They have developed it. And you are very correct in saying that the OCT gives you a better scoring system. And I think the NC balloons and the high pressure balloons, those are not very, very good at cracking this calcium. I think either you do a scoring balloon or a cutting balloon, but I think the rotablation, which used to be pretty good those days, but now with the IVL therapy, we have definitely come to a stage where this is a very safe therapy with a short learning curve. The only limitations is, one is the cost, and secondly, you require probably, if you have a long lesion where you have a difference of a diameter, you probably will require 2 balloons instead of one. So that is probably the limitation. Otherwise, I think the IVL is a fantastic tool which is going to be here to stay. And I'm sure that in years to come, your experiences on IVL you will share with us in this forum. So, Dr. Rai, do you have any questions?
Sir, Nak sir, yeah, while once you diagnose it as huge calcium in the coronaries, when you use the IVL, intravascular lithotripsy, after you try with some NC balloon, when we fail to crack the calcium with NC balloon, then you'll use IVL or all cases of high calcium score?
Dr. Rai, your question was partly answered by Binayak sir, but I will repeat it again. Now, there are scoring methods where we score the calcium. Now, if it is more than one quadrant, more than 270 degrees, then we need to have a better tool to crack the calcium open. Now, we have tools like NC balloon, a cutting balloon, a rotablation, or a shockwave lithotripsy, which is the latest. Now, among all these, it has been shown that shockwave lithotripsy cracks not only the intimal calcium, it also can crack the medial calcium also, if there is. So rotablation does not do that. Only thing is, we need to be sure what we are dealing with. Now, that is wherein the imaging comes in. And imaging by OCT definitely gives us a better view of the depth and how to deal with it. So by doing a plain angiogram and looking at it and saying, oh, I will crack this with a NC balloon or a cutting balloon, those days are like, those were guesswork, I would say. Now we are in a stage where it is all objective, not subjective. So I would prefer to do imaging and then take it from there.
Right. Thank you, sir.
I would just extend Dr. Nag's theory of this angiogram business. Angiogram is a diagnostic tool only, but to give a therapy, you definitely have to go beyond it. Angiogram to me is a stenotic tool, just to diagnose stenosis. But the qualification of the stenosis is very, very important to give a proper adequate therapy. Because as Dr. Rai will know that if the stent apposition is not correct, if you're undersizing a stent, these are the predictors of stenosis and subacute thrombosis. So angiogram cannot be and will not be a tool to give a therapy. It is only a diagnostic tool. And more importantly, if you have a normal angiogram, I think that gives gives you a better result for angiogram rather than if you're an abnormal angiogram. So the normality of an angiogram actually gives you much more information rather than an angiogram which has shown stenosis. Because once you have stenosis in angiogram, you have to not only quantify but to qualify the stenosis from there on to give the adequate therapy, because that's the only way we can actually proceed with the success of PCI. The reasons why the PCIs were not so successful compared to CABGs, particularly in diabetic subsets and vessels with triple vessel disease, was because we were not qualifying the stenosis properly. And that's why we used to have a lot more stenosis, restenosis rates, and the IS are coming into place. So now that we have these tools, I think we require to use these tools judiciously to give a better experience to the patients, long-term results to be comparable with CABGs, and then I think we will be in a better platform to not to be cutting open the sternum for every case. So, Dr. Tripathi, would you have any comments?
Definitely, sir. OCT and IVAS are the definitely the added advantage over the angiogram, and they should be done routinely in all patients, especially in those patients who have a calcified lesion and the complicated lesion. As my next case, cerebral vessel closure, these cases are the ideal for OCT and IVAS. But there are issues with availability every time. But wherever available and wherever feasible, they should be done.
Absolutely. Thank you, Dr. Nag, for your excellent presentation. Please be with us as we proceed to Dr. Tripathi. I'm very pleased to introduce Dr. Gaurav Tripathi. He has been told to us as a young, dynamic interventional cardiologist from Suyash Hospital in Raipur, and he has completed his DM in 2018 from GB Pant Institute, Delhi. So you have trained in one of the best institute of the country, Dr. Tripathi. So over to you for a very, very important topic. And I must say that when I started angioplasty in 1988, 1987, actually, we started with the POBA area. We didn't have stents. Acute closure on the table used to be a nightmare for us. So
Yes,
I would like to really revisit that story again in 2020 and see where you are right now. Over to you, Dr. Tripathi.
thank you. Thanks for the nice introduction, sir, and thanks Abot for this providing this platform to us. Let me share my slides. Are you able to see my slides, sir?
Yes, Dr. Tripathi, we can see your slides.
Good evening, everyone. We were discussing cath lab nightmares tonight, and one of the those is abrupt vessel closure, which can be a catastrophe, especially when it involves left system, left main, and LAD, which is our case tonight. And myself, Dr. Gaurav Tripathi, as introduced by Dr. Binayak, sir. So to start with clinical details, this was a 66-year-old female having a cardiovascular risk factor of hypertension and dyslipidemia, presented to us with a chest pain for 1 day. And her ECG revealed ST elevation in V2 to V6. And echocardiogram done in emergency shows an renal wall motion abnormality in LAD territory with an ejection fraction of 45%. And this is her ECG. At this point of time, patient was hemodynamically stable. Her blood pressure were 140/90, and she was not complaining of dyspnea. She was complaining of chest pain only, and clip 1. So we plan to went ahead with the go ahead with the angiogram. This is angiogram initially done with the right radial route, left coronary system, and so with adequate backflows in a PA caudal view, revealed a tight lesion in mid LAD, following which there was a complete occlusion of LAD can be seen. So to edit information, there is an areocranial view. We can see stenosis starts from the mid portion itself, and following which there is a complete occlusion of the LAD. And at the same point, we can see the origin of two diagonals. So probably a bifurcation point. Adding to the information, we have an areocranial view, which shows us also a disease in the proximal segment of both diagonals. So kind of trifurcation lesion this was. and we can see some retrograde flow from left system as well in the distal part of the LAD. So this was a right system angiogram revealing right dominant system, a normal RCA, and retrograde flow from the RCA as well to the filling LAD. So my plan was to stent LAD only. First, any opinion of house whether we should have went ahead committed trifurcation stenting or LAD? I just want to have an opinion of house on this case.
Do you have epicranial, Dr. Tripathi?
Sir, I have it, but I actually let me show you.
Okay.
This is allocranial. Sir, this is I haven't stored it, sir.
Okay, that's fine. Okay. So yeah, go ahead with your presentation, please.
So my plan, I planned of doing LAD stenting only. So
yeah, this was a provisional stenting technique you went on.
Yeah, provisional I was planning because of a complex anatomy and trifurcation point and acute set scenario, and I was not planning a committed trifurcation stenting in this setup. So I went up ahead with right radial route only, and I started with a fine cross catheter and a BMW wire first to probe it and see what kind of lesion it is. And because of complexity of anatomy, angulation of lesion, and 100% stenosis, BMW was not able to navigate through this lesion. So I shifted to this Fielder FC wire. Fielder FC wire is very much similar to Fielder XT, all polymer jacketed, but not with the tapered end. And there is slight less chances of tracking into 70 mm space. So I preferred Fielder FC for negotiation. And with a fine cross catheter because of acute angulation. And after a few minutes, I realized there was a slowing of flow in diagonals. And at the same time, patient started complaining of chest pain. And very next shot I seen was an abrupt closure of LAD. And because of probably because of I expected a wire induced dissection at the stenotic point in mid LAD or the angulation causes the abrupt closure of blood vessel, abrupt closure of LAD, and same time patient went into acute LVF and pressure started dropping, and I have to stop it here, and I intubated her. We intubated her, and we started ionotropes, and then I plan of shifting to femoral route first. So because of my opinion on this thing is femoral gives you a probably more advantage of having a central venous line and more support and more you can manipulate much better with femoral route in these complex cases. Then I restarted with femoral route. I was not aware of the track. The same, I started with again with the same fine cross and Fielder FC wire because no software would have passed it through, and I needed some support to cross it. And so I started with Fielder FC wire again. And I was not aware of the track where the actually dissection might have happened, and angulation was quite much. So I took a small shot with a fine cross catheter. And I can see there was stenosis starting from that point where was a 90% stenosis in LAD system. So next I took a Fielder XT wire because it has a tapered end and probably much better in navigating through the stenosis. So Fielder XT wire crossed through it. And then I was able to track fine cross catheter to negotiate this bend, and fine cross is here, and I was able to negotiate and put it here. And after this, Fielder XT was not crossing at all because I was not aware of the entire track. Probably I could have taken a retrograde shot though, but I prefer to take a small dice shot from fine cross itself. And I can see there is no tight stenosis after this point, and I took advantage of this situation, and I took a soft wire BMW and I just passed it through. BMW, I make a loop of it and push it through this LED system, and with God grace, it passed it. And now another problem was it was the any fine cross was not going beyond this point point, and then I took a balloon which was not crossing at all 1.59. Then I took a smaller profile 1.2 and a longer balloon 1.2 into 15, and then I started inflation from the this point only, because the lower profile balloon, the maximum profile of the balloon is at the marker side, so we anticipate a slightly lower profile at the distal end. So sometimes they cross into that lesion, and they provide you an advantage. So for balloon uncrossable lesion, probably this should be the first step. Take a small profile longer length balloon, and slowly we went ahead, dilated it further 1.215, and I was able to the flow. And we can see lots of haziness here, dissection probably which have induced an abrupt vessel closure, and finally vessel is open. But I can't see a diagonal here yet opening. So further dilated it with 2 to into 12 balloon. This was a post dilatation flow. You can see a spiral dissection coming from here 3 to here. So and then the next was obviously to extend the vessel. I took a 2.75 24 balloon stent first. My intention was to put it away from the proximal strut, away from the bend, because when you put it the proximal strut near the bend, next stent is harder to put it. So the next stent is like this. So now the problem arises after keeping both stent. We can't see any diagonals. The artery is bald now. So my dilemma was whether to probe it in this complex situation or to give some medicine. I tried intracoronary nicoran and intracoronary adenosine in a fear, although, and after few medication, I can see a TME1 flow diagonal. Both diagonals have TME1 flow. So I myself decided to stop it here only. A patent LED, the large LED, and TME1 flow in diagonal. So a patient was nice and discharged after 3 days stay. So opinion of house is needed whether we should have probe this diagonal and try to save it. A TME1 flow would suffice for this patient.
I'll start with Dr. Nag to give his comments on this case. Excellent case done by Dr. Tripathi. So Dr. Nag, if you have some comments on it.
Probably he's mute.
Dr. Rai, if you have any comment.
That is a very excellent case done, well rescued. Why this fine cross was taken in a very initial time? Why not only a floppy wire was negotiated? Why fine cross from very beginning?
There was a acute angulation which I can
Right.
see more around 90%, and
Right.
many a time under tight stenosis. So fine cross provide excellent support for negotiating these vessels, and a bend we can put across. And we were already expecting exchange of lot of wire in these cases.
Right.
We were just started with probing a BMW, but we were expecting we will need exchange further. And when you have we are expecting a lot of exchange, and you put harder wires in the proximal segment every time without a cover of microcatheter, you tend to damage proximal segment as well.
And what was the reason? Maybe this dissection because of this fine cross, or is it because of
filter
BMW?
FC wire itself, sir. Because of acute angulation and a branch stenosis. They are
Right.
itself a risk factor for dissection. There was branch stenosis in 2 branches, and their acute angulation was there. So any manipulation, even with filter FC wire, was
plus calcification also, played a role. A lot of calcification was there.
Calcification was there, but we were not. We haven't seen it before the dilatation. After the dilation, when we have the balloon uncrossability thing, then we learn to have calcification there.
Right.
Dr. Tripathi, there are a couple of things which I think we all learned from this case, including yourself. What I always find very useful is that once I've done a radial approach and done an angiogram, then just stand back and just take a stock of the situation. And probably I would have gone to the femoral straight away, femoral approach, because you have more control over the whole situation because you have a trifurcation to begin with a very acute angle. So,
So there was a peculiar
and
scenario
you,
with this patient. I would
yeah,
like to,
yeah,
sorry, there was a peculiar scenario with this patient. The lady was not giving consent for femoral root when she was
oh,
conscious.
okay,
And this is a very
okay,
peculiar
okay,
scenario. Yeah, I tried to convince him a lot. His son tried to convince Shiva, I want to allow to touch my
yeah,
groin. So hesitantly, I went ahead with radial route. And once the patient was knocked down, I take an opinion from attendants and went ahead with femoral route.
it's a
So it
very
was a
difficult
peculiar situation.
scenario. I
Even myself
understand.
would
Yes,
have preferred to go with the femoral straight away.
yeah, that's number one. And number two, I think the question which you asked us is that whether you do anything with the diagonal, because I think there are a couple of situations which could have happened. One is that there could have been a dissection in the ostium of the diagonal, which would have closed off the diagonal completely. But because you started to have a TME1 flow, so obviously there was no dissection, and it was a result of a pinching, which would have closed off,
Yes, sir.
or a part of the dissection of the LAD dissection, which would have closed off. And once you opened up the LAD, the diagonal flow started to resume. If you had done an angiogram maybe a week or 10 days later, you probably would have seen a diagonal flowing.
Diagonal.
So
Yes.
no issues on that. Absolutely. I think once you are in acute case, uh, there is no way I think you can think about a two stenting strategy. I think the strategy which you took was absolutely correct. And using a fine cross catheter to actually negotiate that bend was a very, very good idea. Because otherwise, you could have been in a trouble situation, not only with a dissection, maybe a perforation as well.
Yes,
So
sir.
the strategies which you took are absolutely correct, I would presume. And putting the stent proximal to the bend, distal to the bend was also a very good idea, because if you had placed the proximal part of the distal stent on the bend, it would have
Yes, sir.
been very difficult to negotiate the second stent proximally into the second stent. So that
Yes,
was
sir.
a very good decision which you took as well. So I think overall this case uh, was a very big learning case. The only thing I would say that in this particular case, the imaging is absolute paramount, because if you want to know where Dr. Rai said, do you have any calcium, number one, what is the reason for the closure? Once you actually cross the wire into the distal part of the artery, then you have a chance to find out the reason. Was it a thrombus? Was it a
Yes.
dissection? What is the extent of the dissection? Because that is very important to know the proximal part of the dissection. Where did it stop? Because you have to stent from that portion to the end of the dissection. So if you angiographically want to find a dissection, it is a very, very difficult thing, particularly in an acute case. So image here is of paramount importance to actually save the artery and do a complete job. So I'm sure that our friends who are actually doing the show, they would be uh, definitely giving you the support in the coming days to help you in imaging patients. I think my counsel would be that you start off with imaging in simple cases and then proceed to these complex ones.
Sure, sure.
And I think it is always worth to keep a provision for imaging in these complex cases, because nobody is going to forgive you if you say later on that, I mean, this was a complex case and I could not image because of financial issues or other issues. So here the science has to predominate above everything, particularly to for the sake of the patient and also to protect the medical fraternity as well. So this is an excellent case, and very well done, Dr. Tripathi. I think we'll move on to our next case by Dr. Rai. And I want to introduce Dr. Rai. He's a very good friend of mine, and he's at a very young age a head of the department and senior consultant interventional cardiologist and a pioneer of the interventional cardiology process in Sikkim and entire region, because I believe that he was the guy who set up the first cath lab in that region in 2015. and now he's working in SPNM Multi-Speciality Hospital, Government of Sikkim, which is a 1,000-bedded hospital. And he's the lone warrior there who is doing all the fantastic cases 24/7. I'm aware of all the cases which he does and the complex cases we discuss at times. So I'm sure that persons like Dr. Rai would be a jewel in the crown, particularly in this state where not much interventional cardiologists have ventured. He has more than 5 years of experience in the field of interventional cardiology and published papers in reputed and national and international journals. He's a skilled operator and he's accustomed to procedures like CRT-D, septal ablation, peripheral angioplasty, and others. And most importantly, he does not have a cardiac surgeon right now for backing him up. So we can all understand what a difficult job you've been doing, Dr. Rai. So over to you to discuss about unprotected left main PCI.
Okay. Thank you so much, sir. It's an honor to be with you all, sir. Yeah.
Yeah, we can see your slides, Dr. Rai.
Yeah, yes, sir. So greeting from Sikkim, sir. Small state, hill station. So this new hospital we call as Sir Thutup Namgyal Memorial Multispecialty Hospital. Sir Thutup Namgyal was the last king of Sikkim, Chogyal of Sikkim. So inaugurated last year only. So we have started this our cardiology department from March 2019 only. It's a very young department. We have established cath lab, intervention, all kind of comprehensive heart failure, rheumatic, all kind of heart disease. Because being a single interventional cardiologist myself, so it's difficult to work. There's a lot of challenges with me, and we don't have a cardiac surgeon at present, so very difficult. So and shifting patient to facility where there is CTPS facilities there, so that's very difficult because of roads outside, terrains is very difficult in, especially in the rainy season. Almost most of the time the roads are blocked. So what we do is from ourselves, my side, and try to do as much as possible to intervene and yeah, like this. So I have one case, 53 years female. She's non-systemic hypertensive. She had a chest pain of 2 days, very severe chest pain, and 2 episodes of unconsciousness, likely syncope or cardiac arrest. And at emergency, BP was 100/70, heart rate was 110. ECG, there is a diffuse ST, inferior anterior ST depression, sinus rhythm, and we did echo, and there was a global hypokinesia of ejection fraction of 35%. So with that presentation, we started conservative management from emergency, loading everything, heparin, ticagrelor. Then despite that, even after a few hours also, patient was having a severe chest pain. Then we went ahead with coronary angiography. So we are suspecting some critical blockage like left main or proximal IDD on ECG on by clinical presentation. So on angiography, you can see very critical osteal block, in left main osteal block, and even a proximal LED also was stenosis. There was a slow flow in, you can see LED and plaquing also there. Because so then the additional point was we did an RCA also. RCA more or less as a normal, giving collaterals to an LED left side also. So we didn't have much option, much time also, and because our my department is very newer, so we don't have an imaging facility, like you You all have this all kind of imaging, but we have to do it. We have to reverse plus it. So we had go ahead with PCI angioplasty. So I chose the right femoral artery approach. Is easy to maneuver also, and sometimes when if a patient goes into a cardiac arrest, also we can do a temporary pacemaker at the same time, like that. So I feel more comfortable in more severe cases. I prefer a femoral approach, and we took Judkins left 3.5. I took 7 frames, so can maneuver a little bit. And here there was 2 episode of a cardiac arrest and a likely cardiac arrest, 2 episode of unconsciousness. So I took the temporary pacemaker or TPI also, so that being a single operator, I can get overdrive in if patient goes into VT or like that. So I did TPI also, and guide catheter. So how I do is here, because while wiring this critical left main stenosis, after we cross the wire, and there will be no flow. Flow will compromise. What I do is before engaging, I place a wire near the ostium before engaging in the left main. So I keep there, and sometimes I keep a balloon also with a wire. So if I see I can easily negotiate the wire ahead. So I took a, BMW wire, then I engaged and just took this first shot. With some easier maneuver, I could cross and this left main lesion and placed in the distal LED wire. And then in there, I forwarded the balloon also, 2 into 15 mini track balloon. Then I inflated both the lesion, LED, LOS. I took a longer balloon so that I can inflate both the LED lesion and as well as left main. Then I took a shot also. So I could appreciate some of the flow. At the time, patient becomes slightly symptomatic. Then patient had one syncope like that episode. Exactly that at the time BP went down after this check shot after ballooning. Then I went straight ahead with stenting. That is stenting, covering from the ostium of left main to the LED lesion. So after stenting, you can see the check shot. There was an adequate inflation and flow. So that thing. Then we have to do post dilatation. I did post dilatation with 4.5 in the 12 NC track balloon, and even osteal flaring also did. And at the time, vitals were normal. I had a TPI backup. So I did a nice post dilatation, high pressure with osteal flaring also. So after this, you can see flow, adequate flow in left main, LED, circumflex. Some we can appreciate some plaque in ostium of circumflex, but overall flow was nice, normal. Then patient improved drastically, drastic clinical improvement. Within hours, all the pain, angina went off. And patient is in a follow-up. This I did 6 months back. This patient I'm following up. Patient is no symptoms at all. We're doing very well. So in over in last since I started this in Cath lab, I have done 6 left main cases. I'm following up all because I know because there is a limitation, like I don't do imaging, so I'm planning to get an imaging facility. So there is a high chance of stent malpositioning, in opposition, thrombosis and restenosis. So I review patient clinically, and at time, if they complain of any angina, and then I do a check angio also. So in previous two cases of a left main on check angio, absolutely no late loss also. So that I could appreciate. So this is how. And theoretical part, I know, because all are experienced, knowledgeable, so I don't have to discuss all this thing. And importance of this left main, and this importance of PCI, evidence basis of PCI over CABG, all these things we know. That's all, sir. You're open to, sir, your suggestion and your uh, sharing of knowledge, sir.
I think this is an excellent case which you have managed on your own. And believe me, you feel to have difficulty without cardiac surgeon, but when you have a cardiac surgeon on board, you'll understand what difficulties actually is all about. I think Dr. Nag will endorse my views on that. Uh, but I think
Absolutely,
it's an
sir.
excellent case,
Absolutely, I agree
and
with you.
I think if you see the studies based of left main versus CABG, particularly in the Noble and the Excel trials, both have shown that actually the PCI and CABG are comparable results now. They're giving equivalent results now. So there is no reason to believe that you cannot do PCI to left mains even if you don't have a surgeon. So the couple of things. Do you have a intra-aortic balloon pump on site,
Yeah,
Dr. Rai?
yeah, we
So
have
particularly in
IBP.
these cases, I think if you have a reduced ejection fraction, instead of
Right.
putting temporary pacing, you also, I think, have a support
Yeah,
of a IBP
IBP. Yeah,
in these cases. That will
yeah,
give
yeah.
you some time to
Right,
maneuver.
exactly, sir.
And second thing is the
Yeah,
sepal technique. I think for to find that you are actually on the ostium, you don't miss the ostium of the left main, and you're not protruding too much into the aorta.
right.
If you put another wire on in the aorta just to circulate,
Yeah, right.
and then if you pull the stent and if it hits the wire, you know that you are exactly at the ostium and not miss the
Yeah,
ostium, or
yeah.
you are not protruding too much out. So
So
these are the
yes,
two things which I would
yeah,
like to mention.
yeah.
I would ask
Nice, sir.
Dr.
Thank you
Nag
so much.
to give a few comments on this case, please.
That was an excellent case, Dr. DP Rai, and
Yes,
I really appreciate and hats off to you. And with limited facilities, how you
right,
handle the case, this is
right,
a
sir.
real challenge, and I would salute you to handle this
Thank you,
case in
sir.
such a good manner with such good flow. And I
Right, sir.
totally agree with you. Even when there
Yeah,
in the earlier days, when there were no imaging, people used to do these cases, and they
right,
keep on close follow up. What you're
right,
doing
sir.
is perfectly fine without
Thank you, sir.
imaging. You have done a perfect job. I really appreciate that. Thank you, sir.
Thank you so much, sir. Thank you so
Dr.
much.
Tripathi, do you have any comments, please?
Sir, I just wanted to ask whether we should prefer 7 French or 6 French catheter in osteal left main stenting,
Right.
because my own self, I would have preferred a 6F, if 6F catheter. And IBP, as advised by you, is definitely recommended for all left main stenting. And for osteal left main PCI, is definitely comparable to CABG. For LMCA bifurcation, we can have a difference of opinion. For osteal LMCA stenting, definitely can be done. And just wanted to ask whether 6 French or 7 French.
I did with 7 friends. I thought, but I have to change some catheter, another wire also. So for easier maneuverability, I took 7 friends.
Can I come in here?
Yes,
Right.
please, Dr. Nag.
Yeah, Dr. Gaurav Tripathi. Thing is, 7 French helps in such cases where we might need to use 2 balloons in case there is some plug shift into the LCX. We need to cross with 2 balloons, do a kissing. So that was a good planning, in fact, by DP Rai in going ahead with a 7 French catheter. I would also do that. Only thing is, like, if you don't do a 7 French, and you can do with a 6 French if you are using all new catheters and balloons. But with limited facilities where we work in the periphery, you also know that we are using all reused balloons and catheters. So it will be a little more of a challenge if we use a 6 French catheter. Not that we cannot do that. So that would be my suggestion.
Yeah, wonderful.
And Dr. Rai, I think, you mentioned about imaging facilities. I think if you have to choose between imaging, I would definitely prefer a OCT with a
Right,
angio co-registration and FFR integrated,
right.
facility at
Sure.
your center. I mean, that would give you all the parameters.
Right.
Particularly, you require physiological monitoring as well of the lesions. And also, I think if you have an angio co-registration, I think it will help you to actually give you the landmarks when you're doing the OCTs. So that is one thing. And I think your cases which you do, I have seen it. Not only this, all the acute cases which you do are excellent cases, and I'm sure that in years to come, you will be doing with your surgical hand and with the imaging all the difficult cases. The other thing which I wanted to mention is that using side hole catheters during a osteal intervention, to me, is a no-no. The reason is it gives you a false sense of security if you use a side hole catheter, because if it is sucked in a little bit, you will think that the pressure waves are fine, but actually the hemodynamics are actually depressed. So I always prefer to have a catheter which does not have a side hole, because you actually get the actual pressures which are on board, rather than having a false sense of security.
Sure.
So today, I think we'll be concluding our session, and I'm really obliged to Dr. Rai, Dr. Tripathi, Dr. Nag, and Dr. Devinder Singh for their excellent presentation. And let me say, in this particular forum, we discuss more about science and not about financial constraints which we all face in our lives. And particularly, I understand Dr. Tripathi's dilemma when he mentioned about his particular case where the lady patient did not give him the femoral access consent. And that is something which we come across in our day-to-day lives as well. So it's a very, very difficult situation. When you have to switch over, you still need another consent. So these are the practical things which we face in our part of the world, which the Western counterparts don't even think about. So that, I think, you managed very well. And Dr. Nags, I must compliment him that he is one operator who really believes that you do 100% imaging. How much we can achieve in years to come, that's something which we'll have to see, because as we understand that globally only 40 to 45% cases are done with imaging. In US, it is as low as 15%. In Singapore, in a center where there is no constraints of finance, they do left main only 40 to 45% imaging. So I think we have still some miles to go, particularly in terms of imaging. But I think the mindset of the interventional cardiologist is very, very important, particularly people like Dr. Rai, who have a complete control over the whole state. So I think you can definitely be the flag bearers of these imaging systems. So if you can actually introduce these systems into your peripheral systems, particularly Dr. Rai, who is working in Raipur, but I know Dr. Nag and people in our city have the opportunity to do imaging. So I think the mindset of the cardiologist is very, very important. And at the same time, the collaborators, the companies who are actually providing these imaging systems, they must also work very closely with these cardiologists who are young, who are motivated, and who does not need to change their mindset from a time when imaging was not done and people believed only in angiograms. Because I know in globally some countries like France, they do not do imaging at all. They just go on just doing on based on angiograms. I do not agree with that philosophy, even if they have success rate, because I think you are taking a lot of chance, particularly in this era where you are actually comparing your results continuously with the CABG cohort of patients. If you had to do triple vessel disease going to CABG and single vessel, double vessel discrete lesions coming for PCI, that was another story. But now we do all kinds of cases to get comparable results. I'm sure that imaging is definitely the way to go. So with that, I conclude the session, and thank you very much again, all of you, for joining the session on a Sunday evening, and all the best for the coming days. Thank you. Good night.
Thank you so much, sir.
Thank you,
Thank
sir.
you so much, sir.
Thank you, Dr. Rai. Thank you, Dr. Nag.
Thank